Hello and welcome to Unstressed. My name is Dr. Ron Ehrlich. I'd like to acknowledge the traditional custodians of the land on which I'm recording this podcast, the Gadigal people of the Eora Nation, and pay my respects to their elders, past, present and emerging. Well, today we are exploring sleep. Actually, we're exploring the problem of poor sleep, which includes not breathing well while you're asleep. And as we've said many times, a consistently good night's sleep is a function of both quantity. For 90% of the population or more, that's getting 7 to 9 hours of sleep a night consistently. And putting your head on the pillow is not enough. It's also a question of quality. That means breathing well while you're asleep. And let's remind ourselves that sleep is all about enabling you to rebuild physically, mentally, and emotionally, and poor sleep affects every aspect of your sleep. And this is a very sobering statistic that 80 to 90% of people with sleep-disordered breathing problems go undiagnosed. Well, my guest today is Dr. Harry Ball. Harry is one of the most experienced practitioners in the world, establishing the Sleepwise Clinic, which has treated over 14,000 patients with oral appliance therapy, and we talk a lot about that today. Harry is also the immediate past chairperson of the Dental Sleep Medicine Council of the Australasian Sleep Association, and he has restricted his entire practice to dental sleep medicine in Melbourne and in Geelong in Victoria. Harry has provided training programs for dentists throughout Australia and New Zealand, as well as the United Kingdom, Holland, Belgium, Singapore and Malaysia. And he has presented on sleep-disordered breathing problems to GPs and sleep physicians, as well as the Australian Dental Association, the Australian Orthodontic Society and Dental Health Services of Victoria. Look, Harry knows a great deal about this issue, about how best to treat it. I hope you enjoy this conversation I had with Dr. Harry Ball. Welcome to the show, Harry.
Thanks, Ron. Great to be here.
Harry, I've known so much about I've heard about your work in the sleep field, and you are a world leader. I would happily acknowledge that. And we hear a lot about sleep problems, but what are those problems and how common are they in the population?
Yeah, there's a number of different sleep disorders. Probably the most common disorder is insomnia, where a lot of the population suffer from insomnia, depending on what the definition is. But basically, it's problems either falling asleep or staying asleep. So that is, incredibly prevalent. It could be 20, 30, 40% of the population have insomnia. And insomnia is complex because it can be due to medical conditions. It can be due to sleep apnea and to other sleep disorders as well. And then you've got what's called sleep-disordered breathing, which is snoring and sleep apnea. So that's also a very common disorder. And it's kind of estimated that up to 30, 40% of the adult population have got some degree of problems with snoring and sleep apnea. Not everyone who snores has sleep apnea, but if you snore loudly, if you snore chronically most nights and it's loud enough, there's probably got about a 90% chance of having a degree of sleep apnea. And then you've got, and by the way, children can have it as well. It's often related to tonsils and craniofacial morphology, and often they grow out of it as well. But it can be a real problem in children. And then you've got other sleep disorders, to do with sleepwalking, sleep talking, nightmares, all sorts of. I think restless leg is a common sleep disorder as well, where people get movements and twitchiness when they start to fall asleep, and that can have a real impact on the quality of sleep and tiredness. So it is very common, and I think a real trap for dentists is that probably the sleep physicians tell us about 50% of the population have more than one sleep disorder. So it's easy to think you're just treating sleep apnea, but that person can easily be suffering from, say, restless leg syndrome or insomnia as well.
And those issues about sleepwalking and sleep talking are a reflection of poor breathing while you're asleep, whether they're diagnosed as a clinical problem, are they reflective of breathing issues?
Not, I don't think there's a strong correlation, at least amongst the medical fraternity. So generally they'll be treating them with medication, hypnotherapy, counselling, etc. But my view is, and maybe it's because I'm biased, but a lot of the people that we see that are coming with sort of multiple sleep problems, like they've got insomnia, restless leg, and maybe sleepwalking and talking, they've got an underlying sleep apnea problem, and that disrupts the quality of sleep and they're tired of sleep. Yet, and once you fix that, once they start to breathe, and they'll sleep better, and it tends to clear up a lot of the other problems as well. Like when I first started out, you'd see patients come in and they had insomnia, they could barely sleep, but they clearly had sleep apnea as well. And you feel as if, well, you should maybe be referring them out first to deal with their insomnia, send them to a sleep psychologist. But, for a long time now, we just basically treat their sleep apnea. They, all of a sudden, they're sleeping better. They're more confident with sleep. Sleep's not an anxiety-producing time. And the insomnia clears up. That happens a lot of the time. So,
because I think people get told how important sleep is. Yeah. And it's a kind of a chicken and egg thing. They lie in bed and think, "Oh my God, this is so important to my life." Yeah. And I'm not sleeping well, and I'm not sleeping. I'm not sleeping. I think rest is another one that's underestimated. People who just rest. What do you think of that as a concept?
It's sort of interesting. Yeah, I think that rest is really important. I actually did a study with a friend of mine who's a psychologist. This is going back about 15 years ago, and we went into a company and we did we made an audio recording of it's like a muscle relaxation, maybe 10 minutes, and this is with the insurance company AAMI. So they got a lot of their workers there to stop 3 or 4 times during the day and just do this relaxation, and it really had an impact in their quality of life, and taking those short breaks of, you call it rest, meditation. However, it's different to sleep. And it's something that, I've discovered that if you're deprived of sleep, you really need to have a certain amount of REM sleep, non-REM sleep architecture is important. So there's no substitute. And I think rest certainly helps a lot, and you might need less sleep. And I think definitely it's one of the big treatments now for insomnia. So one of the sleep physicians we work closely with, he had David Cunnington. He's kind of a world expert in insomnia and non-drug approaches to it. And he's very much focused on not just what happens when people go to bed, but what they do from the time they wake up, keeping that arousal down so that by the time they get to bed to sleep, they're not kind of hyped up, stressed out from their day. So they're resting, they're dealing with things that might cause this arousal. So to try and prevent a situation where they go to bed and they're really got stressed and hyped up from the day and they're trying to sleep then.
I mean, you mentioned insomnia. We're going to go on to the sleep disordered breathing problems, but sticking with the insomnia part of it because it's such a common problem, and also related to how well we sleep. What do you think about our relationship with light? Because on the one hand, we're told, be careful of the sun. It's very dangerous. And on the other hand, here we are sitting in front of our computers with blue light streaming in. What role do you think the relationship with light has in this issue?
I think light's pretty important from insomnia point of view. So so light at the wrong times can change the circadian rhythm and the kind of pressure to fall asleep. So I think it's generally acknowledged that you don't want to be on computer screens till late at night and subjecting yourself to light at that point in time. But in terms of having light at the right time in the morning, that helps. Helps set the clock. So I mean, one of the best ways to get over jet lag, for example, is to, when you get to a place, you go outdoors and you subject yourself to light, and then that starts to change your body clock. So light's important from that point of view, but then too much sunlight can cause other problems. So light therapy is used a lot to regulate the circadian rhythms that people who are out of phase, especially teenagers who are sleeping in to long hours in the morning, and that mucks up their whole circadian kind of rhythm. They can't fall asleep at the right time at night. So light's used for that. But I was just reading a Facebook post from actually David Cunnington this morning, and he's talking about the fact that he showed an article where this person was realised how much she's having problems with insomnia, and so she's cut out computer screens, etc., beyond about 7 p.m. But in the article, it talks about the fact that she has 6 cups of coffee a day as well, and the impact that has on sleep. So if he sees someone with insomnia, he'll spend an hour just looking at all the different sort of factors and lifestyle, stress, etc., that goes into it.
Before we dive into what the problems are, what does just remind us of what a good night's sleep should be?
Mm-hmm. Well, it's in an ideal situation, you would take about 15 minutes to fall asleep. And you should be ideally going to sleep when that circadian rhythm's there. For most people, it's going to be, somewhere between maybe 10 and 12 p.m. And then if it's taking you a lot quicker to fall asleep, then that's a sign that you're overtired. So we have patients come in, they boast and they say, I'm a really good sleeper. I fall asleep the minute my head hits the pillow. And they're excessively tired, and that's a problem. But they actually boast about it. And then obviously the other side of it, if it's taking more than half an hour or so to fall asleep or longer and you're frustrated by it, that's insomnia. But for most people, it's that 7 hours, and you get people who boast, people like Trump boast that he gets 3 or 4 hours sleep a night. And anyone in the sleep industry knows that is a real red flag for difficulty functioning and making decisions and et cetera. So it's not a good thing for the majority of the population to be getting a lot less than 7 hours sleep. So, and there's research that shows that getting 5-6 hours sleep has a massive impact on immune system health, much more likely to get cancer, heart disease, and shift work. I mean, are you aware of these stats on shift work? How lethal that is?
Well, I am, but it'd be good for you to share it with our listener.
Yeah, so you see the stats on particularly shift work where that shift's changing all the time. Your probability of getting serious illness like cancer and dying early is something like 40-50% more of the general population. Like, having seen the stats, I wouldn't dream of doing any shift work, unless you were paid an amount, danger money or whatever. So, that's a real problem, and also oversleeping. So the research shows if you're sleeping more than say 9 hours or so, you're at risk as well. So everyone's different. There are a few people that can get by with less sleep, but the majority of people need around that 7 as an adult. Yeah.
And tell me, if somebody is wanting to explore that, that they have a sleep problem or not. I know there's a whole process they should go through. Just give us a sort of an overview of what that process looks like in your practice, because I know it's very focused on sleep disorders. Yeah. So tell us what that process is.
Well, it depends what the sleep problem is, so if it's pure insomnia. So in our clinic, our receptionists are trained about half our patients are referred in by sleep physicians or ENT, GPs, etc. And then half the patients just come in from word of mouth or they've seen an ad or something like that. And our receptionists are trained to be able to screen those patients as to whether they're a suitable patient for us, because we're dentists and we specialise in treating sleep disorder breathing, snoring and sleep apnea. And what we don't want to do is, and our initial consultation is 45 minutes, so we don't want to have our books filled with patients who come in and they haven't got that problem and we've got to then refer them out. So if someone rings up and it's clear that they've got insomnia, for example, so our receptionists are really good at listening and asking some questions and ascertaining. In other words, they're doing a screening, and if it's insomnia, and let's say they don't snore at all, so if someone doesn't snore, it's not that likely they've got sleep disordered breathing. So we'll recommend they go and see a sleep physician, and that might be a good place to go. If they've got, just to answer your question, there's some really good online cognitive behavioural therapy type programs which are validated, so people can do that online for insomnia, for example. If it's, the thing is though, if you speak to sleep physicians, you speak to anyone in the sleep area, they'll say most patients come because of snoring, right? They don't come because they've got sleep apnea, because most people don't know. Most people who've got sleep apnea don't know they've got it, in the population. And so it's a snoring problem. And so they come in for that, and then we will manage that.
And then they will do a sleep study, or how would you move on from there?
Right. So you're talking about how we manage a patient when they come in?
Yeah.
So a patient come in and they've already been, we've gone over the years we've made a big effort to put a lot of information on our website. So most patients looking through our website will recognise that, yes, I've got sleep apnea. Now, sleep apnea, it's not hard to recognise. Like once you've been treating patients for a while, you just ask them, like if anyone chronically snores, for example, and it's loud enough to disturb people, and they're also saying they wake up a little bit unrefreshed, despite getting at least 6-7 hours sleep, you can almost guarantee that they're going to have sleep apnea. So, you speak to the sleep physicians and they'll say, you don't really need a sleep study to work out whether someone's got sleep apnea. What you don't know is the level of severity, and that's important because the level of severity will dictate the type of treatment. So it's something we tell patients that, because often patients will say, look, do I really need a sleep study? Because I know I've got sleep apnea, people see me stop breathing and et cetera. But, so we explain to them, yes, I agree with you. Things highly likely you've got sleep apnea, but we don't know the degree of it, because we have people who come in and you swear they've got really severe sleep apnea. Can barely stay awake. People see them stop breathing all the time, and it comes back mild, and in other people, we're really surprised. We'll have someone come in, they're younger, they're not overweight at all, they're snoring, they're not tired or sleepy, and you talk them into a sleep study, and it's really severe, and so you just can't know for sure that individual patient, that level of severity. So we do want to do a sleep study. There's sort of a different bar for us as dentists. So I was speaking to a couple of sleep physicians recently, and there's a trend now not to do a sleep study. Like if someone snores regularly and they'll do a medical, they're basically medically fit, they're not tired or sleepy, the research tends to show that an oral appliance would be fine for someone like that without having to go to a sleep study. And that's something that's changed over time. But as dentists, we can't do that assessment. And based on the kind of guidelines that we have, we really should be doing a sleep study on everyone, on anyone that snores. Because what I say, snoring is a sign of obstruction. So if someone snores regularly, they're obstructed. And so you want to do a sleep study on them. So to answer your question, the patient comes in, we will speak to them, we'll confirm their symptoms, and then we'll educate them, because that's all part of the process. They need to understand why they would do a sleep study and what sleep apnea is. And you have to do that because a lot of times they'll come in just for snoring, and that they're not really, they either don't know about sleep apnea or they're not interested in it. And our job is to try and get them interested, because you want them to do a sleep study. So that's the challenge, when those people come in.
What do you think of, I've done a sleep study, I'm sure you have too, and you're hooked up with all these different tubes and wires. And I know if I go to bed with my watch on, it irritates me, and I don't get what I would call a normal night's sleep. And yet with all this hardware on, what's the view, either personally or across the profession, of the accuracy of those kind of tests?
Yeah, look, it's a good question. And when I started out, all there was the overnight sleep study in a hospital. And patients had no confidence in the results of that because they got a bad night's sleep. They're all wired up and they can only sleep on their back and they're in a foreign bed and there's noise all over the place in the hospital, etc. So that was an issue. And then home sleep studies came into effect probably 10, 12 years ago, and they've got more and more unobtrusive. So I think most people can do a home sleep study without too many problems. And the ones we're using now, with a couple of sleep physicians, we've set up a diagnostic service for dentists, and it's based on an instrument called the Cpap. Have you heard of that at all, Rob?
Mm-hmm. I have.
Yeah,
the watch.
So that's simply, it's just like, well, you've got to at least wear a watch. So you're saying you have trouble with a watch, but
yes. No, but that's relatively minor in comparison to what.
Yeah, it is.
What do you think of those? I've just recently been exploring. Well, obviously, I'm wearing my Oura Ring, and I've tried wearing a Whoop band, and there is Snore Lab, and there's all these different apps. What do you think of that? Even Sleep Image is something that's a little more recent that I've been looking at. What do you think of those as a way of assessing or giving us a snapshot of our sleep quality?
Look, I think it's. I'm only just talking about feedback that I get from sleep physicians. They kind of feel it's not quite there yet. I mean, it's definitely something that it's going to be, and the Apple Watches, etc., can assess sleep to an extent. But I think that for us as dentists, I'm not sure how it'll help us because we need to do a sleep study where a sleep physician's involved. So we're not going to go ahead and make an appliance based on that data. And so I think the something like the Watchpad is that simple to use. You've got a sleep physician doing a report on it. I would just do that, and then basically most of the patients we see, they've got mild to moderate sleep apnea. If they've got severe sleep apnea, then you'll kind of monitor it differently. But let's say mild to moderate sleep apnea, then you're mostly treating their symptoms. You're treating their snoring and their tiredness, etc. And that's what you're targeting. And more sleep physicians are not even ordering like a second sleep test for people with mild to moderate sleep apnea. As long as they're feeling good and not snoring, they're kind of happy with the treatment. I think it can be overkill to start using oximetry and doing all these assessments for people. And I've spoken to sleep physicians that they don't really want us as dentists to be doing those things, because if we start doing those things, the patients then get reassured that they think they're being looked after, and they're a lot less likely to go to a sleep physician afterwards. So the sleep physicians feel as if the patients are not getting the proper assessment. So if they're severe, then they really need to go back to the sleep physician, do another sleep study while they're, say, wearing the appliance, for example. If they're mild to moderate, then most of the time they don't need to do another sleep study. And I just think you can get a bit obsessive by looking at the technology. And you asked about things like Snore Lab, and I made this mistake about 4 years ago. I loved Snore Lab. I thought it was great, and I was using it a bit. And I thought I'll write a blog on my website all about Snore Lab and send it to our database of 15,000 patients. And all these patients started using Snore Lab and saying, "Oh, the Snore Lab is showing, that I'm still snoring," and stuff like that. And you would say, "Well, is your partner happy?" "Yeah, my partner's happy, etc. I feel good, but this is what the Snore Lab's showing." So, people can get really obsessed by it. I think Snore Lab's really, it will use it. So, for example, if someone hasn't got a partner at all, but they've got sleep apnea, Snore Lab's good because if the person's snoring's improved, then we feel as if we're heading in the right direction. They haven't got a partner to give feedback. So I think there are indications for it, but I just think there's a lot of that technology can trigger people who start to get a bit obsessive about their health.
Yeah, no, I think obsessive is the right word, because having worn an Oura Ring myself, when I wake up in the morning and my wife says, "Oh, did you sleep well last night?" When I first got it, I'd have to say, "Hang on, I'm just going to check."
That's right.
And she said, "Okay, you're not allowed to get out of bed. When I ask you that question, just answer it," because you can get very, very obsessed with it. You mentioned different appliances, and you mentioned the fact that you've either got you're snoring, you could snore and not have obstructive sleep apnea. You could snore and have mild, moderate, or severe. You mentioned appliances. Let's talk a little bit about what those appliances do and when they're appropriate to use.
Right. So you're talking about mandibular advancement splints. Yep. So,
but I know what that is.
I know.
Let's not assume. Let's not assume.
Yeah.
Okay.
So basically, it's an upper and lower device that goes over the teeth, and it's got a mechanism for holding the lower jaw forward. And because the tongue is attached in the midline to the mandible anteriorly, if you bring the jaw forward, you kind of open the airway, you tighten the muscles, etc. So it has a positive impact on increasing airway size, and so it's very effective. So if you're looking at just snoring itself, it's and we've done a study on 100 of our patients, and we found around 96 out of 100 were really happy with the results of the snoring. So it's a very effective treatment for snoring, and in my seminars, like I might have a sleep physician involved, and I make the assertion that as dentists, we have got the best treatment for snoring. So you go online, and there's a million different treatments out there, but I'd ask the sleep physician to name a more effective treatment for snoring, and there isn't. So that's not known by dentists. You've got massive amounts of people who are concerned about their snoring. They're looking for cures for their snoring. There's so many shonky treatments out there for snoring. Yet we as dentists have got the only thing that it's got 96% chance of working. So, you've got sprays and pillows, and you've got all sorts of things. Cpap machine will get rid of snoring, but it's really overkill. No one's going to use it, just for snoring. Surgery, most people are not going to want to have surgery for their snoring, and it doesn't work great unless you speak to an ENT, and they'll tell you how great it is.
It's actually an interesting point, this, isn't it? That depending on the patient's or the person, let's say person's entrance point here, will determine what they are offered as an alternative. Because if it comes via the doctor through a sleep physician, whether it's snoring, mild, moderate, obstructive, they will almost invariably be offered a Cpap machine, won't they? Is that your experience, Harry?
When I first started out over 20 years ago, they just didn't know about appliances. It was just Mickey Mouse type thing. And here I'm wanting to conduct a dental sleep medicine practice, and I'd have patients come in, I'd take impressions, I'd speak to a sleep physician and say, don't bother, with an appliance, So I used to send sleep physicians literature and go around, but the evidence wasn't that great. But over the last, and by the way, Cpap was discovered, as you know, in Sydney by a sleep physician there, Colin Sullivan. So and it's now around the world, and there's companies on the stock exchange selling Cpap machines, and it's massive business. But especially in Australia, which is the home of Cpap, all the sleep physicians are trained. It's all Cpap. So that was the only treatment, especially when I started out. So really had my work cut out with oral appliances. But that started to change, and probably I'd say this studies started coming out validating oral appliances, and the group in Sydney, Peter Sesturli and others, did crossover studies with groups of patients in the severe group who had Cpap, then they changed to an oral appliance, and then they did all sorts. They not just looked at their apnea index, but also looked at all these quality of life measures, etc. And they found there wasn't a lot of difference between Cpap and oral appliances for most patients, and the reason is that the average Cpap use is 3 or 4 hours per night, so we can talk about compliance of Cpap, but, we're very lucky as dentists that we've got an opposition, because there's only 2 treatments for sleep apnea, 2 main treatments, and that's like Cpap or oral appliance. And
just for a second, because we've used that expression a few times, Cpap, and again, I know what it means, but just give us Cpap 101, very, very high level.
It stands for continuous positive airway pressure. So it's a mask, a hose attached to a machine which blows air through the airway, keeping the airway open mechanically. So it's just to stop the collapse of the airway. So someone who's got more mild sleep apnea, the air pressure required to keep the airway open is not as great. And someone with severe sleep apnea, the air pressure is a lot higher and it's harder to use. So, but ostensibly, you've got to sleep with a mask and a hose blowing air through the airway. And CPAP's come a long way. You know, they're not noisy. They humidify the air, and they're really computerized machines now that can actually measure the degree of sleep apnea. But at the end of the day, compliance is still poor. And
what is that? What does the literature tell us about compliance for CPAP? Meaning how likely people are to actually use what they've been given.
So I can talk a lot about that because it's been an interest area of mine. But
I'm sure it was. I wanted to ask you.
Well, so there's a couple of different ways to look at it. A major study came out recently of 4,000 patients, and it was a multi-center study which all the sleep physicians were very interested in. It was looking at whether CPAP was going to prevent mortality or deaths. But one of the main issues that came out, the average CPAP use was 3.3 hours per night. You know, so lots of studies are showing it's around the 4-hour mark, 4 or 5 hours. Because what happens is that obviously the people with sleep apnea are pretty tired and sleepy. So a lot of them can fall asleep with the CPAP on, but then they'll wake up after a couple of hours, say to go to the loo. They're not quite as tired anymore. And you've got this machine blowing air through. They can't go back to sleep with it, so they'll just leave it off. They won't travel with it. And so average use is low. And so, like, if you're not using your CPAP for 3 or 4 hours a night and yet you're stopping breathing 20, 30, 40 times an hour, that's a lot of time that you're getting obstructions and all the health implications of it. So CPAP use is a problem. And there are companies that sell CPAP, and I've seen some of their stats. And so they'll have patients referred to them for a CPAP trial, and about a third of the people, when they look at what it is, they say, no way known. And I get patients saying this all the time, I'd rather die 8 years younger than use that machine, right? That's what they say.
Right.
And so they actually refuse outright. So that's about a third. And then that leaves 2/3 that give it a trial of about a month. And of that 2/3, about half just say, look, I can't use it, because it leaks or they can't get the right mask or it irritates their cheek. There's a whole lot of things that can happen. And then you've got the remainder, a half of 2/3 who will use it, but then they're using it not all the time as well. So they're the stats. And when I speak, in the past, I've spoken to sleep physicians and I tell them all this. And they say, oh, no, but my patients use it, 90% of the time. I spoke to a sleep physician recently and I really like the way he operates. So basically, and this answers your other question, more and more the sleep physicians now are deciding which patients really need the CPAP and who needs an oral appliance, and they refer out a lot to oral appliances now. So I can talk, especially in Victoria, where almost everyone who is in the mild to moderate range now, they'll mention an oral appliance. And are you aware of the American Academy of Sleep Medicine guidelines now?
No,
so the
go
American
on.
Academy of Sleep Medicine, they're like the peak body in the field. They changed their guidelines recently, and they've said that every sleep physician needs to include an oral appliance as well as CPAP. So it becomes like a choice for the patient because what happens in the past, the sleep physician would just recommend CPAP, and when the patient fails CPAP, they then think there's nothing else for them because the oral appliance hasn't even been mentioned. But now the guidelines say they need to at least, that they might say, if they're in a severe group, they might say recommend CPAP in the first instance, and if they're intolerant of CPAP, then an oral appliances. But for the mild to moderate, they'll say it's the patient's choice. And so the sleep physicians now that I speak with and work with, if the patients are in that subgroup where sleep apnea, where a CPAP machine is really indicated, so there's no question that that there are people where CPAP is definitely their best option, by a long way too. But you're only talking about a small group of people. So you're talking about people with really severe sleep apnea. Their sleep apnea is just as bad on their side or on their back. They're overweight. Let's say they've got blood pressure, heart problems, diabetes. Those people should be given every opportunity to use CPAP. And the sleep physicians will recognise a patient like that, and they will educate them and motivate them. And those patients will often do really well with CPAP because they know they should be using it. And if they're educated properly and motivated, then it's true. Like if you just refer that group out and they're educated and I've got a good CPAP therapist that works with them, 95% will use it. But those stats that you see in the literature is when sleep physicians are referring off everyone for CPAP, and people who are mild will they're just not going to be interested. And anyone who's not symptomatic, there's no way they just don't use CPAP, even though they could be severe.
Yeah. Because, I can relate to people who say, I'd rather die 8 years earlier than wear a CPAP. But if the reality was you are going to die in the next 8 years, there's a motivation for using it. Mandibular advancement splints, though, I mean, you mentioned that they're 96% effective in terms of dealing with snoring. Well, what's the compliance like for that? Oral appliances?
It's a really good question because, it's interesting. You got sleep apnea and, everyone wants to just take a magic pill or somehow prevent the problem and deal with the cause. But the reality is that the two treatments are relatively intrusive. You either got a machine or you put an upper and lower device in your mouth. So compliance is really, really important. So with the oral appliances now, if they're made properly, and we made a transition in our clinic about 4 years ago to 3D printed nylon, and it is so thin. It's just we've got to the point where I think anyone who is serious can use it easily. Because
right.
I mean, just to backtrack a bit, there's a lot of different appliances out on the market, and I've got slides where from about 5 different manufacturers, and they all say we've got the gold standard, the best appliance, and these are companies on the stock exchange, and it's just rubbish, really, because there's been something like, I think it's 12 or 13 studies back to back comparing appliances, and there's never a difference really shown. So the actual style design of the appliance really doesn't matter. It's to do with holding the jaw forward. So you hold the jaw forward, it does the job, So, but what is really important are two things. One is how comfortable is the appliance? How easy is it to use? How easy is it to titrate or to adjust and bring the jaw forward? And what about the side effects? So there's a real different profile in side effects from the different appliances. So that they do vary. So when we made the transition to nylon, we started to get no fractures at all. So fractures is a really bad side effect. So if you're using acrylic,
breaking the appliance is breaking.
So the research shows that if you've got sleep apnea, you're probably twice as likely to have bruxism as the general population, clench and grind. And everyone in practice sees that as well. And, you can argue as to why that's the case, and there's all theories, but the fact is that they do coexist. And so you find that, we went for 15 years doing all acrylic appliances, and I would say if someone wore an appliance for, say, at least 8 years plus, probably 80% are going to fracture them, break them at some point. They might get a crack in it, and then over time it'll break off. And it'll usually happen while they're sleeping in the mouth, when they're sleeping, and they wake up with a bit of acrylic floating in the back of the mouth, and they're freaked out. And in my seminars, I show emails where people love their appliance and they wake up choking, and they're really nervous about wearing an appliance again. So it's a really bad side effect to happen, a fracture.
Yes.
And go on.
No, I was going to keep going because that's one side effect.
And there's been cases of patients. We've had patients swallow them and then swallow bits. But there was dentist in Sydney who talked the patient inhaled a bit, and that's a really serious side effect. So acrylic's a brittle material. To stop it breaking, you kind of make it a bit. You have to make it thicker. The thicker you make it, the less comfortable it is. So the materials are really important. So there's really three materials. There's the hard, soft, laminate type materials. So they're really comfortable, but they tend to be quite flimsy. They're more flimsy, and they're more likely to fracture and crack. The good thing about them is that they usually bits don't break off because the soft material keeps it more intact. But with nylon, I mean, even the thinnest, our appliances go down to 0.2, 0.5 of a millimeter, and they just don't break. I saw it in America at the American Academy of Dental Sleep Medicine meeting, and I couldn't believe it. I came home and I got hold of some of the nylon appliances. I drove my car over it. I just couldn't break it, I'm not showing you the videos.
Patient wasn't wearing it.
Well, it was my appliance.
Oh, okay. But listen, you mentioned titratable, and that means it's adjustable, meaning that you put an appliance in and it stops snoring, but a few months later you need to adjust it, move the jaw slightly forward, which means titratable. Are those nylon appliances titratable?
Absolutely. Yeah. So they have a method, a system of bringing the jaw forward. So they've got these little tabs in the side, and you just take one out and insert another one, and it just brings the jaw forward. So,
and nylon is also a little bit more flexible.
It's flexible, which is nice. It's comfortable, and one nice thing is it's thermoplastic. So if you put it in boiling water, if you dunk it in for 10 seconds, it actually softens. So if a patient has some restorations, or if you want to tighten it or whatever, you've got that sort of flexibility. So it's a really nice material. We haven't had no fractures, because in the old days before that, every day we would have 2, 3, 4, 5 phone calls of people fracturing an appliance.
Now, another side effect, because I think these mandibular advancement splints have the potential to change people's bite, doesn't it? I mean, we used to, I think, Harry, probably were of that era too, where correcting clicking jaw joints was something we strived for. And the mandibular advancement splint can do that, but in the process, it can change bites too, can't it?
Yeah. So we're not talking about side effects. So there's two side. The side effects. The majority of side effects are temporary. You put in an appliance, you get a bit of extra saliva, teeth might be maybe a bit tender, but if everything fits well, normally after 3 or 4 days, everything's comfortable, etc. So the only two side effects are a percentage of patients get TMD problems with it. It can trigger
temporomandibular joint.
So jaw joint problems. So maybe about 8% of patients will get that, and it's usually only in the first 2 or 3 weeks. And they're usually people who have never had a temporomandibular problem before, so that's a whole other conversation. But the good news about that is that it's normally pretty easy to deal with, resolve, and in my experience, it's never a deal breaker. You get them through that period, and then they're fine. So that's the temporomandibular situation. By the way, you have to educate doctors and sleep physicians about it, because they think that it's going to cause arthritis of the joint and all these irreversible changes, etc. So that's been part of what we've done. I've sent newsletters to sleep physicians and kind of educate them about side effects. But then you've got this other area of occlusal changes, bite changes. So that's real, and that happens, and it'll happen to a large percentage of patients that will wear an appliance. It usually doesn't happen in the first 2 years or so. So it's a very slow process. If it happens in the first 2 years, and so bite change will happen because there are very gentle forces on the teeth from an appliance. So even though you wear one and you don't notice it, I mean, I've worn one for a long time, you don't notice any forces, but they're gentle enough to actually cause upper teeth, especially anterior teeth, to retract slightly, lower anterior teeth to move a bit more labially. And you can get some bite changes over time. And so they start to, if they happen in the first 2 years, the consensus is that they're reversible. You just take out the appliance and it bounces back. And that's been my experience as well. So if we have a patient who comes in and they're vulnerable to bite changes, for they may have just had ortho, etc., we'll get them in every 3 or 4 months and just check. That first couple of years is important, because if they are getting it, then they can choose maybe not to wear the appliance. But you don't want a situation where, and it does happen, where you put an appliance in, and they know they should be coming back every 12 months or so, and you there, Ron? It says your image has gone off the screen.
Oh, look, that's the beauty of this platform, Harry. You can just keep talking, and we're recording
no problem.
As we speak.
Yep. Yeah, so I was saying that, what you don't want, and unfortunately it happens where you put the appliance in, you tell the patient they've got to come back every 12 months, and you don't see them again for 8 years. And the reason you don't see them is because they're happy with it, everything's going really well, but they've had a pretty big bite change. And the bigger the bite change, the harder it is to deal with, and so you don't want that.
Which surprisingly, Harry, in my experience, they're not unhappy with
exactly
either.
Right. So,
I mean, that's what I find most remarkable about it. It happens, but the patient themselves are going, yeah, look, my bite feels different, but I'm not uncomfortable. And as a dentist, we kind of
it's so true. I mean, I'd have a patient come in like I've described. They come in, say, after 10 years, and I say to them, "How's it all going?" "Oh, really good, yeah." And they don't mention bite change. They open up and you have a look, and it's, my God, And inwardly I'm going, my God, but I'm trying to act cool,
Yeah. Stay calm.
And I say, "Oh, look, I noticed that your bite's changed a little bit, and if you notice it, yeah, it has a little bit. Is it worrying you?" "No." So you're absolutely right. For the majority of people, it is not a problem at all, even severe ones. Our biggest problem is other dentists, right? So what will happen is the patient will get a bite change. It might be a small one. They'll go to a dentist, or they might change state, and the dentist will look in their mouth, and the patient hasn't even noticed a bite change. The dentist will go, "Oh my God, what's happened to your bite, etc. We've got to send you to an orthodontist." And then they go off to an orthodontist, and the orthodontist has a look and says, "Well, we've got to do surgery and braces, etc." This happens, I can tell you, and because everyone's focused on ideal occlusions, ideal treatments.
Yes.
Yep.
Minutia.
So over the years, patients will ring me, and they'll be upset, and they'll say, "You never told me about this bite change," And of course we do, because it's a really big part of informed consent. So I can't overemphasize the importance of having signed informed consent. So when they say, "You never told me," we just print it out and say, "Well, you signed this," and that's, so it's good to have that for a start. But most of the time, I'll get them to come in and we'll chat, and most of the time the bite changes are such that the patients are happy with their appliance. I mean, you wouldn't get a bite change unless they've been wearing it for a long time, and no one wears it for a long time unless they're getting good result. And so they do want to wear it, but they're also not happy with the bite change. But look, most of the time I have a prosthodontist that I refer to, and he might just do a bit of equilibration here or there. So instead of having, say, 3 teeth in contact, they might have 4 teeth on either side. They might still have an anterior open bite, for example, but all of a sudden it's mostly a functional problem. I can chew. They're happy with that, and they want another appliance. So like when they go down that pathway of orthodontics, it's all for perfect treatment, and so. But having said that, there's ways of minimising bite changes now. So so these sort of things don't happen. So I don't know if you're aware of some of those methods at all, Ron.
What, like the morning appliance or some exercises to take the jaw back to where it was?
So we'll make up it's a thermoplastic material where it's like a little anterior jig where they'll bite into their centric occlusion before they get the appliance, and then every morning they will bite into that.
Yep.
And also they'll know if there's any change as well. And then there's a few other strategies that we'll use to minimise bite changes as well.
It's so interesting though, Harry, isn't it? And that is that for a lot of dentists focused on the minutiae of what goes on in the mouth, where we are talking down to microns sometimes, we lose sight of the fact that there's a person attached to a respiratory system, and a good night's sleep is life-altering and
That's a
sometimes
really
life-saving.
good point, Ron, because the dentist is just focusing on the occlusion and whether the correct number of cusps are touching in the right fossas. But you step back a bit, and the appliance is having a really big impact on their quality of life, their health, and I mean, I'm a dentist. I've got an edge-to-edge bite. I'm really vulnerable to bite change. But my wife is a really light sleeper, and if I want to be in the same bed or travel with her, I had to wear an appliance. And
Absolutely.
And I know there's a lot of dentists like that. That okay, if I get bite changes, I get them, but the positives far outweigh.
Harry, you've just described my whole life too there. My teeth are edge to edge like that, and was faced 20 years ago with the choice, your snoring has become a problem, either move out of the bedroom or do something about it. And it was a revelation to both my wife and myself that I finally did something about it, and both our health improved as a result of it. I mean, I often say I have more energy now at the age of 67 than I have.
How valuable is that, Yeah.
Absolutely. Listen, you do a lot of training for dentists and doctors and all of this, and I think I saw some statistic. There are 100,000 registered doctors in Australia, and I forget how many registered dentists there are. Do you know offhand?
Dentists?
I'm not sure.
Yeah, I'm not 15 to 20,000, something like that. Yeah.
Yeah. And what percentage would you estimate are familiar with these issues of sleep disordered breathing and the dentist's role in that?
Yeah. So, and there's been a couple of studies on it showing how much is covered in the undergraduate dental program in universities in Australia and New Zealand, and it hasn't changed. Something like 2 or 3 hours is devoted to dental sleep medicine, and usually by a lecturer who's never really done or operated in the field at all. So the dentists don't get a lot of training whatsoever in the field. There is more and more interest in dental sleep medicine in Australia. It's really taken off in the US. So in the US, it's really big there. There are a lot of companies training dentists all over America, and the dentists are really kind of into it. And in fact, the American Dental Association has now come up with guidelines that every dentist should be screening their patient for sleep disordered breathing. So it's a recommendation, because dentists are looking in mouths. They can see some of the telltale signs, and we should be doing it. And so if you're doing that, you may as well be treating them. But here, I think there's a growing interest. I mean, I've been doing training programs for maybe over 15 years or so, and it's one of these things, the dentists either are really interested or they're not. It's one of these things, you have to have a bit of a real interest or passion in it. You can't just do it for the money kind of thing. It's because there is a learning curve. You're a bit out of your comfort. It's different to any other area of dentistry where you can just go in there and do whatever you want to do. Like if you want to do a root canal or denture, whatever, you just go ahead and do it. But here, it's a medical issue. So you do have to work together to some degree with sleep physicians. And dentists, for their first, say, 4 or 5 appliances or cases, they're out of their comfort zone, and there's a real barrier there, and they don't know how to do it. Doing a sleep study is a real barrier in Australia for dentists. How do you organise that for your patients? There's really big barriers through Medicare for that, and it all becomes hard for dentists. So what we do in our training programs is very much break down those barriers and make it really simple to screen the patients, because, if you've got 2,000 patients, a lot of those are already had sleep studies and they've failed CPAP, and they'll be really good patients. So you should be screening your patients, and then especially, and that's what's called a low hanging fruit. That patients have already had sleep studies, and they don't know anything about oral appliances, and you've got a good relationship with your patients. So there's patients there that would be, ideal candidates, and you'd be contributing a lot to their health and quality of life.
Absolutely.
But to answer your question, there are these barriers. So we've set up a diagnostic service to help dentists. We do mentoring programs, and so it's there's more and more of an interest in the field, because there's a lot of patients you'd have without even doing any marketing at all, and it's just like in our own practice. In the city, we have 6 dentists working part-time, and all of them don't like general dentistry, so, and they're in their 30s mostly, and they've just had enough of general dentistry. They love this field, right? They love it, Well, you'd be aware, because I know you work in the field. Yeah, you got.
Yeah.
It's more interesting.
It's so much more
interesting. Got satisfied patients, I never got patients telling me how great my margins were, kind of thing.
Yeah, the edges of your fillings, how beautifully you polished a filling or anything. No, but change their life like that. Another one that dentists are always looking at, and a lot of patients are very aware of, is clenching and grinding of teeth. And I know that has changed. Our perception of what the cause of that is has changed over the last, particularly 15 or 20 years. Can you
about
talk
clenching and grinding?
About that change?
Yeah.
Yeah, like how it was viewed 15 or 20 years ago, how it's viewed today.
Well, you'd probably be aware as dentists, we thought we had the answer, was to do with occlusion and the way the teeth fit together would cause bruxism now. But, I mean, we know that bruxism is what's called centrally mediated. It comes from the brain. And yes, it definitely, when people are more stressed, they're going to brux more. And the feedback I've got during COVID, the high levels of stress in the population, the amount of bruxism, you just hear that all the time. I've got a couple of patients who are psychiatrists, and they're telling me the degree of stress and tooth fractures and things like that. So stress is a part of it. I think bruxism is probably the most undertreated and managed sort of disease amongst dentists, because I'm talking about. I mean, if you look at the effects of bruxism, yes, it can cause TMD, but most of the time, people are pretty much asymptomatic. They might get a slightly sore jaw, they might get the odd headache, but they're getting wear on their teeth. They're getting significant wear on their teeth, and those teeth should be protected. The easiest thing is just to wear an occlusal splint, right? I've got a 24-year-old son. He's already into dentine in a few areas. And what's he going to be like when he's 40? I mean, so the easiest thing is to wear just an occlusal splint. It's underutilized greatly. Dentists should be doing, 2 or 3 a day, really, if you look at the number of people that but I think the trap is, and I've looked at why don't dentists do them. And I think that first of all, you've got to educate the patient properly, because these patients haven't got symptoms. They're coming into you and you're telling them they've got a problem. So you've got to make sure they understand what that problem is. Use some visual method of patient education. But the splint's got to be super comfortable, or they're not going to wear it. And that's where nylon is really good for protecting teeth. They just click it in, barely know it's there, and they're likely to wear it longer term. With acrylic, my experience is they're motivated to wear it for 3 or 4 months, and they forget why they really need it. They start leaving it out, and it's all a bit much. So it's got to be, the splint's got to be really unobtrusive, got to educate the patient, show them models of their own teeth compared to unworn teeth. Use the intraoral cameras as well. And it's a great service for patients to be doing that.
Yeah. Quickly, we've almost finished. We've covered some territory here, Harry, and I just wanted to ask you very quickly, because ever since James Nestor's book came out, Breath, I'm sure you're probably aware of it, and I know we had him on as a guest, and then he talked about mouth taping, putting tape on the mouth at night. What's your view of that?
Look, I think it's a really good thing, but probably for maybe a different reason. I think there's no doubt that nasal breathing is what we're meant to be doing. We're using quite a bit of taping, and I think we need to be doing more of it, because the main appliance that we make is it's called a a Advance. It's a nylon. It's like a dorsal design appliance, but it's an appliance where the upper and lower are not connected. So it's really comfortable. Patient can open and close, and
Yep.
And so there's a lot of every appliance has got pluses and minuses, and there's a lot of pluses with that one. But the minus is that the jaw can drop down during the night while the patient's sleeping. They breathe through their mouth, and so and we all know that if the jaw can drop down, the appliance doesn't work as well for that group of patients. Most patients sleep with their lips together, jaw in the rest position. But if your jaw's dropping down, and there are a lot of patients that will do that, the appliance is not going to work as well. So they're coming back saying, I'm still snoring, even though they've advanced the jaw enough. And taping the lips will prevent a lot of that happening and help them breathe through their nose as well. So I think it's a really good thing to do. And I was just looking at a study recently which showed that the results were better when patients did that. So I see it as a combination. There's a lot of combination treatments of things that you do with an appliance that really help get successful outcomes.
Yep. Well, Harry, thank you so much for joining us today and sharing your wisdom and knowledge with us and experience. And we will, of course, have links to your website so people can find what it is you're doing and all the things that are going on.
Great.
Thank you so much. Well, that's every time I speak to one of my guests, I learn something new, and I hope you do too. There was actually so much in that episode. And actually, I thought what was most interesting was a reminder of dentists. Dentists deal with such minutiae. I mean, we deal with an accuracy of fillings that is in the order of 10 microns. Now, to put that into perspective, a hair is 20 microns. And dentists get very, very pedantic and particular, which is just as well they do, because it's what defines a successful filling or crown, that things have to fit incredibly accurately. And the person's bite is so sensitive that if it's not quite right, they can pick up 10 microns as well. So if a filling is too high or a crown is too high, you will have a sore tooth or teeth that are sensitive to temperature, particularly cold. So dentists get lost in the minutiae of the mouth. That's one of the side effects of being a dentist. But taking a holistic view of dentistry reminds us that actually there is a whole patient attached to that mouth, that tooth that we are so obsessed with. And that person has a respiratory system. And it's worth remembering as a dentist and as a patient too, and as a health practitioner, that the size and shape of your mouth determines the size and shape of your upper airway. And we've said this many times in this podcast that 95% of the population in our modern world do not have enough room for all 32 of the teeth that we have evolved as humans to have in our mouth. That means you have crowded teeth or narrow jaws, and that means you have a narrow upper airway, and that means you don't necessarily have enough room for your tongue in your mouth, and that means the likelihood of you snoring or having a sleep-disordered breathing is very high. And that means that as dentists, we need to take a step back from the minutiae of doing really good fillings and crowns and remind ourselves of the much bigger, arguably, role we have to play in ensuring that our patients have a consistently good night's sleep, which, as we said at the beginning of this podcast, is a function of both quantity, getting 7 to 9 hours sleep a night, and quality, breathing well while you are asleep. And that is the role that oral appliances and in the mouth, which are custom-fitted appliances that support the jaw and the airway in a more balanced and healthy way. We'll have links to Harry's website and all of the great resources he has on there. I hope this finds you well. Until next time, this is Dr. Ron Ehrlich. Be well. This podcast provides general information and discussion about medicine, health, and related subjects. For content is not intended and should not be construed as medical advice or as a substitute for care by a qualified medical practitioner. If you or any other person has a medical concern, he or she should consult with an appropriately qualified medical practitioner. Guests who speak in this podcast express their own opinions, experiences, and conclusions.